Well, good afternoon, everyone. I'm Dr. Shannon Zank, Director of the National Institute of Nursing Research, and I'm so pleased to welcome you all to this NINR Director's Lecture on Systems and Models of Care. Today's event is the third in a series of webinars that we are hosting to provide an in-depth look at each of the research lenses in our new 2022-2026 strategic plan, which we launched in May of this past year. Next slide, please. Before we get started, I'd like to remind everyone that today's lecture will be recorded and made available through our website, ninr.nih.gov. Closed captions are available and may be enabled at the bottom of your screen. Next slide, please. I'll begin by telling you a little bit about our strategic plan. At NINR, we are committed to leading nursing science to solve pressing health challenges and inform practice and policy, optimizing health and advancing health equity into the future. Our mission statement reflects our belief that nursing research is the key to unlocking the power and potential of nursing. And our strategic plan describes how we want to leverage the strengths and unique knowledge and perspectives inherent to the discipline to the benefit of all people. Next slide, please. The plan includes 5 research lenses that we think help push nursing science to innovate, think bigger, and greatly increase our impact. When we say lens, we're describing a perspective through which to examine a health challenge. The lenses in the strategic plan are health equity, social determinants of health, population and community health, prevention and health promotion, and systems and models of care. Next slide, please. Today's webinar will focus on our research lens, which aims to address clinical, organizational, and policy challenges through new systems and models of care. Through this lens, we encourage nurse-led systems and models of care that consider how to leverage the public's trust in the nursing workforce, to employ solutions informed by nurses' experiences and expertise, and to focus on health promoting care that encompasses the whole person in context. We're interested in supporting nursing research that informs the development, dissemination, and implementation of systems and models of care and grapples with challenges such as coordinating care and integrating data across clinical and community settings, testing models of contextualized care, and understanding the impacts of organizational practices and policy on quality of care and its outcomes. Next slide, please. Through this webinar series, we aim to help nursing researchers better understand and apply NINR's research lenses to their own work. We have 3 learning objectives for the series. First, we want to provide a forum for discussion on how nursing research can help address our nation's most pressing health challenges. Second, we want to provide examples that illustrate the possibilities for scientific inquiry through NINR's research lenses. And third, we want to discuss practice and policy implications of nursing research through each of NINR's lenses. You can use the Q&A module to ask questions at any time during the webinar. We will hold questions, though, until the end and try to get through as many as we can. We're also pleased to offer continuing education credits for today's webinar. So stay with us to the end for more information and a QR code to scan to obtain credits. Next slide, please. So I am delighted that we have 2 distinguished speakers with us today to talk more about research through the systems and models of care lens and the implications for policy and practice. In the interest of time, I'll give brief introductions. More complete bios are available on our website. Our first speaker is Dr. Lucine Pogosyan. She is the Stone Foundation and Elise D. Fisher Professor of Nursing at Columbia University School of Nursing. and Professor of Health Policy and Management at the Mailman School of Public Health at Columbia University. She is also the Executive Director of Columbia Center for Healthcare Delivery Research and Innovations. Our second speaker is Dr. Ellen Marie Wellen. She has served as the Chief Population Health Officer at the Center for Medicaid and CHIP Services since 2015. She joined the Centers for Medicare and Medicaid Services as a senior advisor at the Innovation Center in 2011, where she coordinates the maternal child health portfolio across the Innovation Center. Dr. Pagosian and Wellen, welcome. We are so pleased that you could join us today. Dr. Pagosian, I'll turn things over to you to get us started. Thank you.
Thank you so much, Dr. Zhang. I'm going to share my screen and excellent. Well, thank you very much for a very generous and kind introduction. I would like, first of all, to thank NINR for inviting me to deliver this lecture today. What an honor and privilege to have an opportunity to talk about a strategic plan that I feel like I've been waiting for my whole career. Thank you, Dr. Brian, for organizing and working with me on this series. And I'm thrilled to share the stage with Dr. Wellen. And thank you, everyone, for joining and finding time to join us today. I am extremely excited about this strategic plan. I fundamentally believe that it's going to move the nursing science to a new direction and produce impactful, novel science that is going to shape patient care and the health policy. And I hope I am going to communicate my excitement and passion about this strategic plan during the next 30-35 minutes with you. So in those 30-35 minutes, I am hoping to very briefly mention the NINR strategic plan, because Dr. Zhang provided an outstanding overview and about the importance of this plan for moving nursing science forward. I would specifically focus to systems approach to healthcare delivery. Most of my talk is going to be focused on providing examples of research through examples of scientific inquiry through systems and models of lens, because my team and I have been doing this type of research for many years. So I'm hoping to provide these examples and to help see how an NINR strategic plan can help us to produce this type of research and really impact patient care and outcomes. I will also share with you my passion about training the next generation of nurse scientists. I really think this is an outstanding time for us as academicians, as researchers, as clinicians, to think about how to train the next generation of nurse scientists who have the skills and expertise to conduct research, to move an NINR strategic plan forward and produce the most impactful nursing research. And I'm going to leave you with some ideas about potential research, because specifically for nurse practitioner workforce, because that's what my team and I do. But I'm hoping if there are new investigators there who think about how their research can really support and move an NINR strategic plan forward. One of the things I want to highlight and emphasize that NINR strategic plan lenses are overlapping. So we need to think about, as nurse scientists, about how to create innovative, bold, novel research studies that are really address all of these equally important lenses, but also think about these lenses overlapping. And I'm hoping to give you some examples of research, how these research questions can be overlapping and fit various lenses of an NINR strategic plan. As Dr. Zhang gave a very nice overview of what is an NINR looking when we're talking about systems and models of care, an NINR is looking for research that is going to address clinical, organizational, policy challenges that is facing our country. And these models can take advantage of the robust expertise and the experiences that nursing workforce has, and really focus on a health promoting care that encompasses the whole person in the context of their lives and living conditions before, during, and after points of care. So this is a general what NINR is looking when we're talking about systems and models of lens. Those of us who do health systems research have seen many versions of this framework. And this is a systems approach to healthcare delivery. The center of this approach is the patient. We produce evidence to really improve patient care and patient outcomes. And this type of approach looks patients as the center, as partners in the care delivery. These patients are receiving care from clinicians and teams who are the building block of healthcare microsystems. So we need to understand the behaviors, the practices of clinicians who are delivering patient care. In the systems approach, we also look at organizations because patients and teams and clinicians are embedded within organizations which have their rules, practices, resources that is very unique to certain organizations that impact clinicians and teams' abilities to deliver care and ultimately affecting patient care and outcomes. So when we're thinking about systems, we need to consider all these levels. And in addition, the healthcare systems are embedded in a larger contextual environment. This can be financial systems, regulatory market, various factors that shape how healthcare organizations operate, how they create environments for teams of clinicians and clinicians to deliver care to patients, and ultimately determine patient care. So when we talk, this is a general overview. What is the systems approach to healthcare delivery? When we talk about nursing models of care, what do we really mean? In a very simple way is the way nursing care is organized. And these type of care models can be found across the continuum of healthcare. So I'm hoping throughout my presentation, I'm going to give you some examples. Where do we find these nursing care models, including in home-based primary care, in nursing homes, in primary care, and various types of nursing care delivery models have emerged to really accommodate the changing and growing roles and expertise of nurses. Evidence is clear that nursing care delivery models are critical determinants of patient care and outcomes. We have a robust evidence from primary care, we have a robust evidence from acute care that the way nurses deliver care is critically important for patient care and outcomes. So we have to think about that if we're thinking about improving patient care and outcomes. My team and I adopted that framework, and if I were to mention what my team does, this is what we do. Our program of research is guided by this statement, which is maintaining a functional nurse workforce in highly performing healthcare organizations will help meet the increased demand for healthcare services and assure consistent health outcomes for all. This is what we do. This is where we produce evidence to really emphasize the importance of a functional nurse workforce in highly performing organization to assure consistent health outcomes for all. To achieve this main goal, we have studied policies that affect healthcare organizations, particularly the practice environment. And I'm going to give you many examples how we looked at the practice environment within healthcare organizations. They also affect teams of clinicians and clinicians themselves. We have done studies looking at registered nurses, advanced practice registered nurses, healthcare teams. Most of my studies are going to be focused on APRNs and specifically nurse practitioners. And they've also looked how all these levels of the system affect patient care and outcomes. So I'm hoping to, by the end of my presentation, I have provided you examples of studies through these different levels. When I became interested in primary care nurse practitioner workforce earlier in my career, I was building my career, and I wrote this paper more than 10 years ago and made an argument that nurse practitioner workforce represents a substantial supply of primary care provider. Why I was saying this, because I was in Massachusetts at that time, and we know that Massachusetts was the first state that was giving coverage. But that coverage was not really translating into a primary care access for many, many Massachusetts residents. At the same time, I was also noticing that nurse practitioner workforce was growing and was growing very fast. So I put all these arguments and developed this paper saying we need to watch this workforce. They are the key for meeting the primary care demand. Many papers have been published since then, stating similar arguments that we know that primary care demand is increasing. And we know that NP workforce almost doubled between 2013 and 2022, and their numbers are continuing to increase. We know that in United States, primary care is being delivered by physicians, nurse practitioners, physician assistants, and projections show that very soon, almost 1/3 of all primary care providers are going to be nurse practitioners. This is fantastic. Some might say that, wow, we have a growing workforce of nurse practitioners. They're going to help the country to meet the demand for primary care. This is accurate. Indeed, NP workforce can meet the demand for primary care if the barriers that affect NP's ability to maximally contribute to primary care are eliminated. Unfortunately, there are many barriers today at policy level, at organizational level, at workforce level that affect nurse practitioner workforce and their ability to maximally contribute to patient care and patient outcomes. And I'm going to provide my team's researches to produce evidence to really support elimination of these barriers so NPs can really use their training and education to help the country to meet the primary care demand. And this is only one example of a nursing model of care delivered by nurse practitioners in primary care. So what are the policies that really are affecting nurse practitioners? Those of you who do this type of research are familiar with this map. It shows the scope of practice regulations governing nurse practitioner practice across the country. We know that there are obvious variations in this scope of practice regulations. Here, the green states represent states where NPs can provide care to patients to the fullest extent of their education, training, and licensure. The yellow states introduce some kind of reductions in NP scope of practice, mostly requiring physician collaboration for NPs to be able to deliver care. And the red states impose restrictions on NP practice to require NPs to have a supervision by physicians to be able to deliver exact same care that NPs in green states do not have to have. So these restrictions, despite the overwhelming evidence that has been produced over the past 10+ years, that these restrictions are not beneficial for patients, are not beneficial for nurse practitioners, and are not beneficial for our healthcare system in general. So this is an example of a policy that needs to be investigated and really robust evidence to be translated to impact policy at a state level. My team and I even done national studies to demonstrate that scope of practice regulations are critically important for increasing access to care and also reducing cost of care, specifically for Medicaid beneficiaries. So in a national study, we demonstrated that full scope of practice states had lower outpatient costs, had lower prescription drug costs, but they also had a higher total care that patients received. So full scope of practice is critically important to maximally utilize the expertise of nurse practitioners. In our work, you also show that policies affect organizations. Not only policies have a direct impact on patient care and nurse practitioner workforce, we show that policies also affect how organizations hire, recruit, retain nurse practitioners, and create favorable practice environment for nurse practitioners to be able to deliver care. In New York State, we did a pre-post study in New York State when New York State expanded their scope of practice regulations for nurse practitioners. And what we found was that nurse practitioners were reporting better practice environment after the scope of practice restrictions were reduced. So not only scope of practice regulations are important through their direct impact, but they can also impact nurse practitioners indirectly through their impact on organizations. Most of my team's research has focused on organizations because we do believe that initiatives, investments can be made at organizational level to really maximize NP's contributions. We have demonstrated that organizations that have a good environment for nurse practitioners to practice are indeed taking advantage of expertise of NPs and are better at delivering patient care. And I'm going to show you a few examples of that. So when I started the research on nurse practitioner practice environment, at that time, there was no instrument to measure practice environment of nurse practitioners. Because one of you might ask, what is a good practice environment for nurse practitioner? So we received funding and developed a new tool called Nurse Practitioner Primary Care Organizational Climate Questionnaire, NP-PCOCQ. This is the first reliable and valid instrument that measures nurse practitioner practice environment in primary care. It has, and now the tool is being widely used nationally and internationally. The tool measures nurse practitioner practice environment with 4 domains: the relationship NPs have with physicians, the relationship NPs have with the practice leadership, the support and resources NPs have to be able to deliver care to their patients, and how well understood, how visible NP role is within their organizations. These 4 aspects are critically important domains of practice environment for nurse practitioners. So how is it important? We use this tool. I've done many studies. This is just one example of that. And we have demonstrated empirically that if nurse practitioners practice in favorable practice environment on all those 4 domains, then nurse practitioners are more likely to be satisfied with their jobs and have less intentions of leaving their jobs. And later on in other studies, we also show that it impacts nurse burnout. We know that job satisfaction, turnover, burnout are critical workforce outcomes to look at, especially after COVID-19 pandemic that significantly affected the environment and the outcomes of nurses and nurse practitioners. So creating favorable practice environment is important for keeping nurse practitioners in primary care and in their clinical positions to really help to meet the demand for primary care. But we have also shown that the practice environment not only is important for nurse practitioners themselves, it is also important for patient care. So in this study, we merged survey data from nurse practitioners on their practice environment with patient data from the same practices and demonstrated that if NPs practice in favorable practice environment, then patients, especially those with chronic illnesses, are more likely to receive high quality care. We've demonstrated that patients with asthma and cardiovascular disease are more likely to have a guideline recommended care if NPs in those practices report better work environment for them to be able to do their job. So far we have demonstrated that organizations are important. They are important in terms of affecting NP workforce. They're important in terms of affecting patient care. But what we know is that nurse practitioner role was developed originally to address the persistent health disparities that our country has been facing. And I fundamentally believe that NPs can help our country to really achieve health equity, eliminate health disparities, assure that patients have access to high quality, safe care. A few years ago with my colleague, we developed this framework and published it. It's called Nurse Practitioner Health Disparities Model. In this framework, we demonstrated various mechanisms through which NPs can contribute achieving health equity. We've demonstrated that it's critically important to diversify NP workforce. It's critically important to pay attention to the reimbursement policies at federal level, at state level. And it's critically important to look at how organizations hire, recruit, retain, and support NPs. Through these mechanisms, they affect NP supply and practice, potentially primary care capacity, and NP's ability to contribute to reducing health disparities. This framework guided one of our large studies that was conducted in 6 states in US, where we made an argument that how can we reduce racial and ethnic disparities in outcomes of chronically ill patients that receive care in primary care practices where NPs deliver care. We again collected survey data from more than 1,200 nurse practitioners, and we merged the survey data with Medicare claims because we fundamentally believe that NPs have a unique strength delivering chronic care and really helping to better care the aging population in the US who has facing have many chronic conditions. So what we found in this study was that If MPs deliver care to patients in a favorable practice environment, then chronically ill elderly Medicare beneficiaries are less likely to use emergency departments and hospitals. So if we think about how to reduce unnecessary use of acute care services, then we need to make investments in primary care practices where nurse practitioners work, and to help MPs to better manage chronic condition, to support chronically ill elderly, and potentially prevent acute care use. Interestingly enough, in the same study, we have also demonstrated that MP care had a differential outcome impact on Black and white patients. In this figure, what we found that if patients receive care, in Black patients receive care in the poorest care environment practices, then they had higher odds of hospitalization than white patients. But when the practice environment score was the best, there was no difference between Black and white patients. And you can see that in the figure, as the practice environment was improving, the odds of hospitalization between Black and white patients are decreasing. So this is also telling us that we indeed have to pay attention and improving work environment, practice environment of nurse practitioners to really better care for all patients. My team expanded this work in many areas to different patient populations, including utilization, how to enhance structural attributes of primary care practices where MPs deliver care to really reduce emergency department use among high-need, high-cost patients. We specifically look at the MP workforce in community health centers. We do believe that MPs are key providers in community health centers, and they are going to help, and they do take care of the most vulnerable sector of our population. So we have to invest efforts in community health centers to support MPs, to recruit and retain MPs in this setting to better care for patients. We have expanded, so these are examples of nursing models of care, how we were looking at how to remove organizational barriers, how to remove policy barriers, to specifically support this one workforce, which is primary care nurse practitioner workforce. We've expanded into many areas, this research, specifically because I think nurse practitioners are trained and educated with such an advanced skill set that they're key in our healthcare system. We expanded this work into delivering care for persons living with dementia. We know that about 6.5 million Americans live with dementia, and this number is going to increase. We know that dementia is disproportionately affecting racial and ethnic minorities. And we know that dementia is a chronic condition, and nurse practitioners are ideally suited to take care of these patients, particularly assuring optimal continuous primary care, because we know that acute care use is extremely high among these patients with very little benefit. And yet we didn't really know how to effectively use nurse practitioners to better care for persons living with dementia. So we put these arguments in a manuscript published in American Journal of Geriatric Psychiatry, making an argument and very clearly saying that the growing primary care nurse practitioner workforce is a solution for the aging population living with dementia. A very nice editorial was written about our paper, agreeing with us that indeed nurse practitioners and dementia care are a perfect fit, and there is an amazing potential for designing models of care delivered by MPs, supporting MPs to better care for elderly. One example of our study is, we have one study in this area that is looking at the continuity of care delivered by MPs. How can we enhance continuity of care? Because studies show that on average, person living with dementia has 16 visits a year. That is a lot of visits. So we're trying to understand how to use MPs to assure continuity of care so we can prevent unnecessary ED use and hospitalization among these vulnerable populations. And this is a national study. We're collecting survey data from nurse practitioners who deliver care to dementia patients, and we are obtaining Medicare claims to understand how to effectively use nurse practitioners to really prevent these ED use and hospitalization. I'm hoping I will have an opportunity to share the findings of this work with you, either publication or at some other venues. We're very excited about it. I've also mentioned earlier that we look at teams. We need, nobody delivers healthcare alone. And it's critically important to understand how to design effective teams. We have a study that is looking at team design in primary care practices. Those of you who do primary care research know that team-based care is a key for primary care because it emphasizes primary care that is comprehensive, patient-centered, coordinated, and accessible. Yet, when we talk about teamwork and teams in primary care, very often we mean different things. And there is a wide variation about what these teams look like in primary care practices, how to really improve teamwork in teams, and how to improve quality of care delivered by teams. So we have done a study in 23 primary care practices in New York State and in Pennsylvania. We finished data collection like 2 months ago, where we are using a very interesting methodology, system science approach, to understand the underlying attributes of optimal primary care teams. What are the best teams that lead to the best patient outcomes? So we have survey data from teams. We ask everyone in the team, the nurses, physicians, social work, administrators, to tell us about their teams, how they communicate, who they trust, who they go for support or conflict resolution or problem solving. These are important social networks that really tell us information about the team success. And we're merging this data with data from EHR on patient quality of care to demonstrate which teams are the best for achieving best patient outcome. So there's a lot of research in this area. This is another area that we need to really advance nursing science to understand how nurses can work effectively and optimally in various settings with teams to make sure our patients receive the best possible care. We have extended our work into home-based primary care. With colleague of mine and me, we're doing a study right now looking at the home-based primary care delivered by NPs to persons living with dementia. What we know is that many dementia patients are homebound. They cannot go to primary care clinics, and they're not in nursing homes. And we know that nurse practitioners are the dominant provider of home-based primary care. So we need to really produce evidence about how to better support NPs and how to promote their workforce outcome. So in this study, we're looking at teams around NPs when they take care of homebound persons living with dementia. And we're also looking at their job satisfaction, burnout, and turnover intention, because we fundamentally believe these are key outcomes to look at when we are talking about building dementia-capable workforce. We know that this is a national priority. We know that dementia is affecting many elderly and their numbers are growing. So we have to have a robust workforce to take care of these patients. And I truly believe that effectively positioning nursing workforce, in our case, nurse practitioners, can be some of the solutions of these challenges facing our country. We are also expanding into nursing homes. A colleague of mine and I, we just got an R1. I think it's starting tomorrow. The start date is tomorrow, to look at the MP workforce in nursing home. We know that we saw what happened to nursing home during the COVID-19 pandemic. We're joining our efforts in the nurse practitioner workforce and in technology, trying to understand how to support NP workforce in nursing homes to deliver better care to residents who have dementia. We know that many dementia patients are in nursing homes, and we again do believe that nurse practitioner workforce can take a central role to really deliver care in these settings to these patients. So the study is going to start tomorrow. So I'm excited about expanding into this nursing type of models of care in a nursing home setting. So as you see, we've taken this work and have grown into different settings, because that is one of the most amazing thing about nursing workforce, that we are capable, we can, adaptable and innovative, and it can have major impact on patient care across the continuum of healthcare system. One study I am particularly excited about, this study is pending, is looking at how to leverage NP practices to address social determinants of health. I think I mentioned to you earlier that NINR strategic plan lenses are overlapping. And for us, this study is one of those that is looking at how we can enhance the practices that employ nurse practitioners to address social determinants of health. So I'm hoping at one point we'll be able to do this work to really produce evidence and design interventions to help NP practices to address social determinants of health. Those of you who know me know that I am most passionate about is training the next generation of nurse scientists. I think an NINR strategic plan is creating an amazing opportunity for us to think about it. How are we going to train the next generation of scientists who have the skills, expertise to move an NINR strategic plan forward? So we have a T32 training program in our school at Columbia University School of Nursing. And we're hoping to expand this training program, incorporate system science methods to really recruit and retain qualified, diverse cadre of nurses from different backgrounds, cultures, and experiences to conduct research, to design systems and models of care, to address clinical, organizational, and policy challenges, to develop and implement interventions that address the social determinants of health across the lifespan and really help achieve health equity in our country. I think it's critically important. Every study I do, I always think about how can we train the next generation to have skills to conduct novel, impactful, robust research that's going to move nursing science forward. Here are some of the examples of the work of my most amazing trainees. Our trainees are looking at NP care models to address the opioid epidemic in rural areas. They're looking at how to deliver care to multiple patients with multiple chronic conditions, because we know that millions of Americans have at least 2 chronic conditions. How to deliver pediatric care and eliminate health disparities in pediatric outcomes. We know that NP role was designed to really take care of pediatric population. We need robust evidence, and we have trainees who are looking at how to deliver serious care to patients who have a serious mental illness and those who do not speak English as their main language. I am thrilled to see expansion of this work in so many areas and seeing what these brilliant new investigators are going to do and how they're going to contribute to advancement of NINR's strategic plan. But we're not leaving them alone. We're not leaving the new generation alone without any ideas. So we give some tips. So in June 2022, we brought together experts, national experts and international experts to design a research agenda on advancement of research on NPs. Because as a team, we've been asking ourselves these questions. We've done a lot of work in NP area. What else we should do? What else is important to move the nursing science forward? What are some of the questions? And experts came together and answered. We came up with questions that hopefully new investigators will take and conduct research. Some of the examples where we see that nurse practitioners are being increasingly employed in various healthcare settings, school-based programs, home-based programs, nursing homes. How can we better integrate NPs in these settings? We also know that we need to diversify NP workforce. This is an issue for nursing workforce in general. This is a particular issue for NP workforce, and how we can translate the evidence to really have change at practice level, at policy level, at clinic level. So I hope I was able to convince you that research is needed to develop and disseminate systems, new organized systems and models of care research. And NINR strategic plan creates an opportunity for us to be innovative, to think bold, and to be creative, to really produce nursing research that is going to shape the policy, shape the decision-making at a national level, and is really going to make nursing voice really heard and loud. And it's going to help to achieve national priorities, including meeting the demand for care. Healthcare demand is going to go up, and nursing can take a key role in this, and we do need science for that. And an NINR strategic plan is going to help us to produce that evidence, to achieve health equity, to design evidence-based innovations, because nurses are innovators, and it's really important to think about how can we design innovative studies, innovative interventions, but one of the most important things is we need to train the next generation of nurse scientists. This is what is critically important to really grow our profession and produce impactful nursing science. So that's all I had for you today. I have not done this work by myself. I want to thank my research collaborators who have been in my team, who has been with me for many, many years. I want to thank my mentees who are teaching me to be a better mentor every day and teaching me new skills. I want to thank my mentors who supported me, helped me to grow. I want to thank all these organizations for supporting our research. I want to thank NINR for this amazing strategic plan, for inviting me here today. And I am so looking forward to seeing how it will shape nursing science. Thank you everyone for being here.
Thank you so much, Dr. Bogosian. What a great talk. Thanks so much. And it's my pleasure to turn it over to Dr. Wellen to share her perspectives with us as well. Thank you.
Thank you so much. Can you hear me okay? It's always a good question to ask before we start. Yes, you can hear
yes.
me okay?
Yes.
Great. So, well, first of all, thank you for inviting me to participate. I am so excited about the future direction of NINR under Dr. Zeng's leadership. And thank you to the folks in your staff who have helped make this happen. I also want to thank Dr. Bogosian for that amazing body of work. As a nurse practitioner, I am thrilled that we have folks like you really looking at what our care delivery models look like and how we can maximize the role of the nurse practitioner and of course all of nursing. And I feel really happy that our future generation is in your hands as a mentor. So really appreciate all of that work. I only have about 15 minutes today, and I want to make sure that we have time for questions at the end. So what I'm going to do is I will talk on the systems and model of care research lens that is part of NINR strategic plan. But I want to spend a couple minutes kind of being fangirl about the entire strategic plan and talk a little bit about some of the other lenses before I get into the systems and model of care, because I think they're all interrelated. Especially, I'll focus a little bit on equity and the social determinants of health lenses. As you may remember, the first executive order that the president signed was a focus on equity. And at CMS, it has really been amazing that we are looking at everything that we do through the equity lens. Our boss, the administrator, Brooks LaSure, says that asking about equity should never be the last question. It should always be the first. And everything that we bring up, everything that we talk about, everything that we work on, we examine what the role it will have to improving equity, and also really digging in to see if there's anything that we're doing that might be exacerbating it inadvertently. And so it's really a lens through which we are looking and trying to figure out how to do a better job. So again, the fact that you're looking at the research that can support that is, I think, so critical, because we are not doing research, right? CMS is a payer. We don't do research, but we do make policies based on the research that we see. And then, of course, how we can do a better job addressing social determinants of health. We know we can't get to these equitable outcomes unless we support and provide interventions that will address social determinants of health. And again, we are making these policy decisions based on what the evidence is telling us is truly working to improve the outcomes. So I'm the Chief Population Health Officer at CMS Medicaid. And sorry, I've got a cold. I apologize in advance if I cough. We describe Medicaid as a medical assistance program versus just an insurance plan. And Medicaid has long supported states to cover a wide variety of services, including transportation, telehealth, and we support Medicaid was able to pay for telehealth well before the public health emergency. Community health workers, doulas, some of these are required services like transportation. Some are optional services that states can choose to cover if they want. But we've been typically more stringent on allowing states to cover a broader array of interventions to cover social determinants like food and housing. But over the past year, after reviewing much of the research, we've worked with states to provide coverage for services that were not specifically called out in the law as a mandatory or an optional service, but services that would generally promote the overall objectives of Medicaid and CHIP, the Children's Health Insurance Program. We allow states to have this extra flexibility to do what we call 1115 demonstrations. And these 1115 demonstrations are for states that want to do a pilot program to test interventions or care delivery changes with an aim to improve outcomes while still being cost neutral. And of course, we as nurses and many of the folks in the healthcare system realize there's so many things that we could be doing probably in the healthcare system that would improve care while being able to be cognizant and perhaps even reducing costs. And so we allow this flexibility to states. And in this administration, with the huge focus on equity, states have rallied and they have come to us with a variety of exciting proposals to cover interventions to address the upstream social determinants of health and individual health-related social needs. Over the past year, we've approved 4 or 5 different states with a variety of nutrition support and housing services. Remember, that's not something that Medicaid, Medicare, health plans typically covered, but we've been really systematically looking and being very thoughtful to better understand where we think that those interventions could benefit outcomes. This is the first time that we've targeted services to a broader population. Typically, we've limited some of what we've done to folks with disabilities or institutional long-term care needs. And now we're starting to broaden that, again, based on what we're seeing the evidence is to move forward. So for example, we've approved states to provide housing transition services to support individuals' movement from an institutional care to community living, supporting home modification and environmental adaptations to enable individuals to remain in the community and avoid an institutional placement. And we've allowed states to cover rent and temporary housing for up to 6 months for individuals transitioning out of places such as congregate setting, homeless shelters, child welfare system, and a range of other options to transition more people out of homelessness. So again, really exciting that we as a healthcare payer have acknowledged the importance of these services on improving outcomes and allowing states to use their Medicaid funds to pay for them. And in nutrition services, we've allowed states to cover nutrition education, evidence-based nutrition assistance, medically tailored meals for certain populations, in some instances up to 3 meals a day. So again, your strategic plan looking to promote research in these spaces will really help us as we continue to look for ways that Medicaid can be a strong partner. We can work with states to find other ways that we can move the needle forward. And that's just Medicaid. At CMS, Medicare is looking to do the same thing. We're looking to see what we can do in Medicare Advantage. So the policy implications are enormous. So let me move to systems and models of care, which is what we're talking about today. And as I mentioned, while we work closely with states to develop new models of care, I also work with CMS at the Innovation Center, where we design models that a variety of stakeholders will apply to participate. Through the years, there's been over 50 models that the Innovation Center has done. And today I'm just going to talk about examples in 2 different areas, primary care and maternity care, both priorities, I think, for NIH as well as for CMS. So for our new primary care models, we are following the recommendations from the 2021 National Academy of Medicine's report, which is called Implementing High Quality Primary Care, Rebuilding the Foundations of Care. That report included a recommendation. Specifically, it said to pay for primary care teams to care for people, not doctors to deliver services. So all of what the Innovation Center is doing is moving us away from fee-for-service, where we were blind to the outcomes but just paying for the services, to paying in a more value-based way, looking to improve outcomes and changing the way we pay for care to support models of care that ultimately will improve outcomes. And I saw one of the questions that was asked during the previous talk about the role of the RN. And I think the role of the RN is critical in this, as well as nurse practitioners and midwives and a variety of other advanced practice nurses. I've actually written about the role of the RN in primary care in the past. And I will say that there is I don't think there's a single model at the Innovation Center that is moving forward without a deep emphasis on care coordination. And that's what nurses do, right? Nurses have been coordinating care, probably before we called it care coordination, trying to be that person at the bedside, making sure that all the services that the patients are needing. So more research on how we can do a better job, what's happening in the payment field that is not supporting that, and what can we be doing to support that kind of care. And so supporting teams, acknowledging that it's never a single individual, is a really strong movement there too. Who are those members of the team? That's another question that we are struggling with. We're allowing providers to figure that out, but the more we understand the role of those team members, I think the better. Looking at the role of community health workers, nutritionists, social workers, pharmacists have a big part of those teams. And then also consistent with what NINR is looking at, where is that care best delivered? Is it in the home? We have to look at schools for children because they spend so much time there. Is it in the workplace? We are looking to approve models and design models that support care delivered in these different spaces, but need the research to better understand where is it best and what are the guardrails? We have to also be, of course, safety conscious. So what are the guardrails we should be putting in as we look to that? And the last of the models I'll just briefly touch on, also a priority of NINR, is maternity models. I will say I'm very proud of a model that I worked on. I was at the Innovation Center before I came over to CMS Medicaid, and there was a model called Strong Start, where we tested care delivered by midwives in birth centers. And of course, probably not a surprise to many of the folks listening here, that model was successful and found a statistically significant improvement in care delivered by midwives, while also simultaneously saving over $2,000 per mom-baby dyad. The outcomes that were improved by care delivered in birth centers were lower rates of preterm birth, which is a really tough nut to crack, lower rates of low birth weight, lower rates of C-section, and higher rates of vaginal birth after C-sections. So was to be able to work on a model that looked at a different set of providers, midwives in a different setting, birth centers, but this is the kind of work we'd love to have more research so that we know where we can kind of focus some of our efforts. And last, because the issue of maternity health, all of you know, and I don't want to go into the role where we're headed with maternal mortality in this country. We're the only industrialized country where the maternal mortality rates are going up and not down. So there continues to be a big focus of what we can do across all of CMS, Medicare, the Innovation Center, Medicaid. New models that we're looking to develop either at the state level or at the Innovation Center include how can we pay for the care differently to support new models of care delivery? How do we better address mental health issues, which we know postpartum depression, but then also CDC has recently said 25% of maternal morbidity has been due to some kind of a mental health issue. Huge. What can we do to do a better job paying for those services? How do we continue to support the advancement of midwives and doulas? And how do we address access to care in rural areas where these hospitals are closing down? And access is something that we need to be figuring out. If there's a payment model, what's in our CMS toolkit that we can do? And how can we develop models based on some of the research that we're finding? So I'll stop there because I really am looking forward to the conversation and some questions. You can see how the lenses that in the NINR strategic plan are so consistent with the work that we are doing. It's a burgeoning area of research. We are thrilled that NINR is looking to promote that, looking to support new researchers who are thinking about this, and hopefully build a body of research that will take them decades into the future. So I'll stop there and turn it back over.
Thank you so much, Dr. Wellen. It was just great to hear about the innovations going on at CMS and, your commitment to evidence-based policymaking and how NINR research can contribute to that. So thank you. And thank you both so much. Really inspiring talks together. So we do have questions coming in and we'll try to get to at least some of them, but let me start with Dr. Wellen. In terms of thinking about, could you tell us more about what type of evaluation you use to measure the impact of the policy changes and the innovations that you put into place?
Yes, I often talk about at CMS Medicaid, we have evaluation envy for the models that are happening at the Innovation Center. The law, the Affordable Care Act, which created the Innovation Center, has required a rigorous evaluation for every new model of care that's developed there. And so we work closely. There's a large body of researchers at the Innovation Center, as well as I think we've contracted with nearly every big evaluation entity to help us figure that out. I will say a couple other changes in the evaluation pieces. when models were done at the Innovation Center before, we often had to wait until not only the conclusion of the model, but then like a year afterwards while we compile all of that information. At the Innovation Center now, every year they provide an update on what we're seeing. So it's kind of in real time. And so the Innovation Center website, which is innovation.cms.gov, has all of the models listed. And then we have yearly updates on what's happening in the evaluation. So we don't have to wait till the conclusion, as well as some snapshots, which are sometimes like a 2-pager of what we're seeing. And so that's been really exciting and a reason that we're trying to promote even more Medicaid involvement. I will also say that the 1115 demonstration that I mentioned, the law also says that when we give states that ability to do one of these pilot programs, we also require them to do an evaluation. Now, that's expensive, and what those evaluations look like, we leave that up to the state. So if anybody is in a state where their 1115 demonstration is occurring, you should reach out to the Medicaid agency if you want to participate in that evaluation somehow, because we really do want to be tracking when we give these extra flexibilities if they are achieving the outcomes that have been proposed.
Wow, great. Thank you. Let me turn to Dr. Bogosian. From our audience, sexual and gender diverse persons experience significant health disparities resulting from many factors, including difficulty accessing care, and avoidance of primary and preventive care. Nurse practitioners or advanced practice nurses seem well positioned to enhance the uptake of preventive care, such as cancer screening in this population. But then there's little data on sexual orientation and gender identity. So could you talk some about research designs that might help to address this question and promote the idea of nurse practitioner care models as a solution?
Thank you so much. And thank you for the question. It's absolutely critically important, because one of the things I think this requires partnering of researchers who study nurse practitioner workforce and who study gender minorities. One of the things that, I have wonderful colleagues at Columbia University School of Nursing who are experts in this area of research, and we always talk about how to partner and do studies together. There are many, I don't have the best answer because I haven't looked at this population specifically, but I absolutely agree that there is an amazing potential for nurse practitioners to really partner with the researchers or with the clinicians and really address some of the critical health challenges that is facing this population and addressing health disparities. I would say the mistrust and lack of participation in research and hard to reach population. So I think it requires expertise of workforce researchers and researchers who specifically studied this population to design studies that will produce robust and impactful evidence. I have not done that work, but I agree with you that it's critically important. But it requires a multiple expertise.
Yeah, indeed. Dr. Wellen, what have been the most effective changes at CMS to support addressing social determinants of health?
I think for social determinants of health, it's new, right? We're starting to, that's something that we've been addressing, like with housing and with housing nutrition services. But I think better understanding where we've been learning more is better understanding the role of the entire team coming together. That typically health insurance paid for an individual to provide an individual service, typically a doctor to provide a certain service. And the models at the Innovation Center have long been looking to say, we need to maximize the entire workforce. And I think especially now we've learned that through the public health emergency, there's a shortage of many workforce, different providers in the workforce. And we are, I think that's been something that we've been tracking and learning a lot and looking to better understand how that team can come together. And I will say lots of thought about what we can be doing in the RN space. And I know we're almost out of time. Can I just flag one thing, and I won't get into it, but there was a question about school-based care. And we have recently released 2 different guidance to help states better understand how they can support services delivered in schools. That was just over the last year, and we are continuing to look to ways to help support that care delivered in school. And as per the comment, not just in school-based clinic, this is just school care delivered within schools. And I can give more information to folks otherwise, but I just wanted to flag that before we signed off.
Yeah, thanks for doing that. It's amazing. The time has flown by. So we'll have to end it there. Thank you so much to both of you for the great and inspiring talks. So we are going to share, there it is, the QR code. You can scan this for continuing education credits. There'll be a short survey to complete. We certainly want to thank the Foundation for Advanced Education in the Sciences for working with us on the continuing education. So again, I want to thank our speakers, Dr. Bogosian and Dr. Wellen. We are so grateful to you for sharing your knowledge and your expertise with us. We will be announcing the date for our next webinar soon, so stay tuned to our website. And if you have any questions about today's webinar, you can always reach out to us right there at info@ninr.gov. So with that, thank you again, and thanks to everyone for joining. Goodbye.